Hi everyone, welcome to our YouTube lecture on the topic Humerus. I'm Shanmugapriya, your lecturer from SNS College of Allied Health Science. Today we are tackling humerus, the big bone in our upper arm. Why care about humerus? In the OT, you will deal with humerus fractures, shoulder surgeries, and anesthesia blocks. Knowing this bone helps your preparation instruments, position patients, and avoid complications like nerve damage. We will cover its structures, ossification, then also with muscles, blood supply, surgical applications. Let's start with the first slide. So here's a starting point. This slide tells us we are focusing on humerus, a key player in upper limb anatomy. As in anesthesia and OT technologists, we will see the humerus in action during fracture repairs, shoulder arthroscopies, and nerve blocks. Our job might involve setting up surgical tools, ensuring the patient's arm is positioned safely. This lecture will give you the knowledge to shine in those high pressure OT moments. So now we are just going to deal with the introduction to humerus. Alright, let's get to know that humerus is a long bone in our upper arm running from the shoulder to the elbow. It's like a structural support for all our arm movements, lifting, throwing, and even waving at a friend. It forms two key joints, shoulder joint with the scapula and a ball and socket joint for mobility, and also the elbow joint with radius. Then we are just going to deal once again. So I will why this is a big deal for us. The humerus is a fractures hotspot, especially from falls and accidents. Think of an elderly patient tripping and breaking their humerus, a kid falling off a bike. And in OT, we will assess the surgeries like open reduction, internal fixation, or where surgeons realign the bone to fix it with the plates and screws. And then the anesthesia technologist, you might help with the brachial flex block to numb the arm for surgery. And also for parts of the humerus has three main zones: proximal end, shaft, and distal end. Let's make this visual. So proximal end, the upper part near the shoulder. It guards its head, anatomical neck, surgical neck, and tubercles. Think of it as a shoulder anchor. And then shaft. So it is long, strong, middle, and like a sturdy pipe. Distal end, the bottom part at the elbow with bites like capitulum, trochlea, that making it bend and rotating possible. The proximal end connects to the scapula for shoulder joint. The shaft handles forces but can snap in trauma. The distal end forms the elbow with fossa dips that let the radius and ulna to move without bumping. And then we are just moving to the fourth slide. So let's focus on proximal end, the shoulder end. The head is smooth, round ball that fits into the scapula glenoid cavity. Forming the shoulder joint, it's super mobile, letting you swing your arm, but that makes it unstable, like a golf ball on a tree. The anatomical neck is narrow and also groove where the joint capsule attaches. The surgical neck just below the tubercles is a fracture magnet, hence the name, as it often needs surgery. The greater and lesser tubercles are bumps where the rotator cuff muscle grabs on, keeping the shoulder stable. So in the OT angle, surgical neck fractures are common in older folks from falls. Muscles like rotator cuff can pull fragments out of the place. So surgeons use plates, screws to fix them. You will prepare the drill or ensure the sterile field is tight. Anesthesia technologists might assist with the interscalene block near the shoulder joint. Imagine a 70-year-old with a surgical neck fracture in the OT. We are going to set up for ORIF, ensuring the surgeon has the right screws and the patient arm is positioned to avoid the nerve damage. So in the next session, we will be starting with the shaft of humerus. Thank you.